Okay, it is officially 1 o'clock, and I know everybody has lots to do. So in interest of time, we're going to just get started. I am pleased to welcome all of you to our second in our series of 3 webinars. Before we get started, I want to take a minute to introduce all of you to Plum Creek Recovery Ranch's Clinical Director, Kelly Aubrey. Kelly is a licensed professional counselor and has a wealth of caring and compassionate experience in the field of addiction, treatment, and recovery. Prior to joining Plum Creek, Kelly was the program director at Phoenix House in Austin, Texas. And we're so thrilled that she's now with Plum Creek Recovery Ranch. Kelly, the floor is yours.
Hi, thank you, Laura. I am really excited to be on the Plum Creek Recovery Ranch team. I'm looking forward to our collaboration with Dr. Covington. We have been busy developing a highly clinical treatment program utilizing evidence-based practices, including some of Dr. Covington's curriculum, as well as some great material from Hazelden. It is so important to us to create a treatment program that is both gender and trauma responsive. So I look forward to our opening soon, and thank you all for joining us today.
Awesome. Thank you, Kelly, and welcome. We are super excited to have you as such an important part of the Plum Creek Recovery Ranch team. Just a couple of housekeeping things. We reserve time at the end for a Q&A session, so please do submit your questions using the Q&A feature on your screen. And at the end of our time, Dr. Covington will be able to answer those questions. Let's see. Oh, I should probably introduce Dr. Riding. We had an issue at the facility today, and there was a chance that our executive director wasn't going to be joining us. So I just went on through with my own spiel. So anyway, let me go back to this. I want to introduce you all to our executive director, Dr. Patricia Riding. Dr. Riding has over 30 years of proven experience in the field of addiction, treatment, and recovery, as well as acute psychiatric care. Prior to joining Plum Creek, Dr. Riding was the executive director at Gateway Foundation in Chicago and Sierra Tucson in Tucson, Arizona. Dr. Riding, I'm so sorry. Please, hello.
It's not a problem. It's one of those days. I just want to welcome everyone. So glad that you're here for our second webinar and can't wait for the third. So let's not wait any longer. Please introduce Dr. Covington. Thank you.
Yes, absolutely. Thank you. So as soon as everybody finishes, there's going to be an evaluation, and I'll share that link at the end of Dr. Covington's presentation. And as soon as you fill that evaluation out, you'll alert me, Laura Comstock, and I will get your certificate of completion and your CEU. So now it is an honor and my pleasure to welcome our presenter for the day, Dr. Stephanie Covington. Dr. Covington is an internationally recognized clinician, author, organizational consultant, and lecturer. She's a pioneer in the field of women's issues, addiction, trauma, and recovery, and she literally wrote the book on gender responsive treatment and trauma-informed care. So without further ado, please welcome my friend, Dr. Stephanie Covington.
Thank you, Laura, and welcome to everyone. You know, talking about, we made this decision about doing addiction and trauma, but I know everybody on this webinar knows what trauma feels like, either from the experience of what's happened, just with the experience of COVID, for those of you in Texas who've been part of the ice storm, the lack of water and power, people in Mississippi still without water. It's really quite amazing, but it's all also about our resilience. So what I'm going to do first is talk a little bit about addiction. For those of you who were on last time, we talked about addiction today, much like the slide shows now, that in fact, you know, today when we think about addiction, it's well recognized that it's considered a brain disease. We know it hijacks the pleasure center in the brain so that other things that normally bring pleasure to life are no longer important. We call it a pediatric acquired disease because for many people, this process really begins at an early age, that if people start drinking or using other drugs in their adolescence or earlier, the risk of having a problem in their adult life is dramatically increased. Today, we also have medication-assisted treatment known as MAT. We know that there are things available that can reduce craving, which really can assist people so that they can participate in treatment in a more engaged way. Motivational interviewing, which I'm sure you're all familiar with. Think of the old days in addiction treatment. It was confrontational. The idea was you tear somebody down. We know when we look at risk factors that there are many risk factors. One, of course, is the genetic predisposition, 50–60% of the risk, but there are many other risk factors also. We also used to only talk about abstinence, but now we also realize the value of harm reduction, of helping people to reduce the harm that's created by the misuse of alcohol and other drugs. And the other piece we know today in addiction treatment is about being trauma informed and trauma responsive. That many years ago, this was not, there we go. This was not part of our programming at all. And if we look at the history of addiction with trauma, initially it was totally ignored. I mean, it wasn't even, the word was not used. It was not an issue. It wasn't discussed, not acknowledged at all. Then we moved to acknowledgement, but it still wasn't part of treatment. We saw addiction as primary. That's what we do here. That's the sole focus of our treatment. And in fact, a mantra developed in the addiction field. And the mantra was this: well, yes, if you have any trauma issues, you'll work on those after you've been in recovery for a year. There was absolutely no expectation that that would be part of treatment. But we've had an evolutionary process here. We've moved from ignoring to acknowledging. We've moved from saying it could follow treatment. Now we know it can happen at the same time concurrently with treatment. And part of that's based on the research. We're studying post-traumatic stress disorder and substance use disorders, and found that if you only treat the substance use disorder, I don't know
Sorry
why.
about that. That was me trying to mute myself.
Okay, thanks. I'm thinking, well, what's happening here?
That was me.
It's okay. If you only treat the substance use disorder, the PTSD gets worse. But if you treat the PTSD, the substance use disorder gets better. So we've realized this needs to happen together. And now this buzzword becoming trauma informed that everybody's using, often without a definition, but we know now this has become a best practice, that we know that we need to include trauma in our treatment. So here's some definitions I use. Basically, I see the trauma work on 3 different levels. The first one is trauma informed. Like I said, the buzzword everybody's talking about. Becoming trauma informed are the things we all need to know about trauma. Then there's being trauma responsive. And that's what we need to do because of what we know. It means we look at our policies, our practices, the environment, essentially the culture of our treatment programs. And we think about this because we're working with trauma survivors. So there's trauma informed, trauma responsive, and then trauma specific are the actual services we provide, the programming that we provide to the clients, to people seeking services. And there are 3 key elements that staff needs to know and clients need to know. Certainly, staff needs to understand trauma. Our clients do too. People seeking services can often have experiences in their lives that we realize are traumatic, but it might not be what they would call them because they don't know what the definition of trauma is. People need to know common reactions, both staff and clients. Very often when people hear about the common reactions, they say, really, I've just thought I was crazy. Okay? And then develop coping skills. When we're working with people who've been using alcohol and other drugs, and if we're in an abstinence-based system we're working in, we're asking them to give up what might be their primary coping skill. So we have to help them develop other coping skills. Laura, for some reason, you're moving slides.
That's strange.
Yeah.
Let me go back. It says you're controlling the screen. So
I know, but I don't know. I'm going back.
Okay.
Okay.
Sorry about that.
So we're going to go back to the definition of trauma, which is what I wanted to do next. So the definition of trauma, if we look at the DSM, the DSM changed this a couple of years ago. So it's exposure to actual or threatened death, serious injury, or sexual violation. This exposure can happen in one of four ways. You can experience it yourself. You can witness this event happening to somebody else. You can learn that this traumatic event has occurred to someone you care about and love. And this fourth piece was added on in the last DSM-5. Experiencing firsthand or repeated extreme exposure to adverse details. This would be our first responders. Would it also be people in behavioral health who are working with people who have experienced trauma and abuse? And so there's the event, but there's the second piece, and that's the response to the event. So it's not just an event, it's the event and the response. So having this experience, then the person's ability to work, to be connected to other people has been impaired. And so it's the event and the person's response. And so the same event can happen to someone, but in fact, one person will be traumatized and one won't. And so trauma can take many, many different forms. We think about it, particularly for kids, abandonment and neglect, but there can be childhood emotional, physical, sexual abuse, witnessing violence in your neighborhood or your family, being kidnapped, for someone being outed when their sexuality or gender identity is shared without consent, working more in understanding the trans and non-binary folks, being dead named, meaning someone uses your birth name, not the name that you are going by, being rejected by family, friends, community, getting kicked out of the house, living on the streets, losing a loved one, domestic violence, rape, sexual assault, witnessing murder, gang violence, being arrested, all kinds of different kinds of accidents, medical abuse, as well as experiencing, having medical frightening procedures or having serious illnesses, war and combat, immigration-related issues, climate trauma, natural disasters. By the way, that's what we're calling what's happening in our climate now. It's not that we haven't always had earthquakes and fires and floods and cold weather and all kinds of things, but now it has increased dramatically, and it's called climate trauma. And then we have intergenerational trauma. And this is the cultural or historical group trauma that happens across generations. And so, for example, in the United States, this in particular would be our African-American population, our Native American population, Native Hawaiian and Native Alaskan people, as well as Japanese families in World War II who were put in internment camps. So it's something that happens to a group of people, and then the impact impacts people over generations, over time. We also talk about big T and little t. And this is the work of Francine Shapiro, who develops something called EMDR that many people are familiar with. And the big T traumas are the things that we associate with post-traumatic stress disorder, death, physical abuse, sexual assault. But they're also what we call little t's. And these are the things that may not seem particularly serious or intense at first, but they impact a person. And these are the things like being humiliated or bullied, being threatened. We see this with teenagers being shamed on social media. And what would be a big T or a little t really, again, is individual. It depends on how the person experiences and their response to it. The responses to trauma are quite varied. You'll find in all my work, I talk about the inner self and the outer self. And the inner self are our thoughts, feelings, values, and beliefs. And so the inner self, thoughts, feelings, values, and beliefs can be impacted by trauma. The outer self, our behavior and our relationships. Okay, and so we can have what happens to our outer self. So the responses are to the inner self and to the outer self. So we're going to look at this process of trauma chart just to get an idea. And if some of you were on before, we did do this before, but I'm going to sort of condense it a bit today. So you have the event. And what happens is this event overwhelms someone's capacity to cope. It overwhelms their physical and psychological coping skills. And then we have the more immediate response to the event. And this is where we hear about fight, flight, or freeze. So there's a change in consciousness, their body sensations. Often there's numbing that can be psychological or physiological. The person may become hypervigilant, always scanning the environment with concerns about danger. Hyperarousal, the body's all revved up. And what happens over time is the person develops a sensitized nervous system, and there are changes that happen in the brain, both in terms of brain chemistry as well as brain processing. And when that happens in a child, it actually develops the architectural developmental architectural aspects of the brain. And then there's some form of psychological or physical distress. It could be a current stress. Coming into treatment could be a stressor. Being arrested, some major stressor in one's life. It could be a reminder of the trauma, which we often call a trigger or an activator or a reactivator. And these are thoughts, feelings, smells, sensations, memories, can come from just about anywhere. And then we see the emotional and or the physical responses. So we have the retreat responses, the isolation, dissociation, depression, anxiety, what we might call the mental health responses. And this is where we would have post-traumatic stress disorder. The harmful behavior to self, that's where we would have substance use disorders, eating disorders, the deliberate self-harm, and the suicidal action. Another thing that can happen is the harmful behavior to others, the aggression, the violence, the rages and threats. And then we have the physical health issues that are also part of the behavioral or physical response to trauma. Now, the Adverse Childhood Experiences Study, the ACE study, which I'm sure many of you have heard about, has been incredibly informational in helping us understand this. You know, the study was originally done with over 17,000 people in San Diego, where I am. It was done in 1998, a long time ago. The first 10 years, no one paid any attention to it. It's probably the most important study ever done in healthcare. No visibility. But in the last 10 years, it has really been embraced. And there were 10 questions that these people were asked, all before age 18. Things about emotional abuse, physical abuse, sexual abuse, physical neglect, emotional neglect, what kind of a family you grew up with. Did you lose a biological parent? Was your mom being treated violently? Maybe there was an alcoholic or drug using family member that you grew up with, a mentally ill, chronically depressed family member, a family member who was in prison. So people 50, 60, 70 years of their life answered these 10 questions about life before age 18. And they found that these adverse childhood experiences had a profound effect on people's lives 30, 40, 50 years later. If you had a score of 4 or more, it put you at greater risk later in life to be a smoker, to be struggling with alcoholism, to be injecting illegal drugs, and obesity. They also looked at health conditions and found that in fact, there were all these health conditions, heart disease, autoimmune diseases, lung cancer, pulmonary disease, substance use disorders. So the connection between these adverse childhood experiences before age 18 became a way for people to assess who was at risk later in life for a whole variety of things, of which addictive disorders were right there at the forefront. Now, there are 2 things about other things they learned in this study that we often don't hear much about, but I want to share with you because I think they tell us a lot about what we need to be doing. Number 1, by the way, the study that was originally done at Kaiser with the CDC in San Diego then was in 5 different states across the country to have a more diverse population in the US, and now it's around the world. So the first thing, the staff at Kaiser did not want the study. What they said is, we can't ask people these questions. We're opening a can of worms. And I'm sure many of you over the years, if you've been a proponent and felt like the agency or wherever you're working should do more about trauma, you've heard from staff, oh no, we can't open this can of worms. Well, Kaiser people said exactly the same thing. We don't have enough mental health staff. We can't ask these questions. We can't open this can of worms. So with those 17,000 people, a staff person carried a pager 24 hours a day, 7 days a week for 3 years, in case anyone who was involved in the study ever became overwhelmed and was struggling and needed to talk to someone. And over those 3 years, out of 17,000 people, they did not receive one phone call. The people who had the meltdown were the staff, not the people receiving services. So often, one of the barriers to getting good services into our programs has to do with the response of staff. And I believe part of this is because many of the staff can be struggling with the same issues and are very concerned about what will it be like to be talking to our clients about this. That may be an activator, a reactivator, or a trigger for me, right? So it's about staff needing to do their work around this. The other thing we learned from this is if people had a high score, and high score was 4 or more, by the way, they received one appointment with a mental health professional. And that appointment was about an hour to an hour and a half. And they found that that hour to an hour and a half appointment with the mental health professional was incredibly impactful. The use of physical health care in this medical system went decreased. And to a person, everyone was so curious about being asked these questions. There was hardly anyone who had ever been asked these questions before. People said things like, do you think it makes a difference? No one's ever asked me, so I figured it wasn't important. One man said, you know, when I was 5, I tried to tell my mother, but she said this doesn't happen in our family, so I never told anybody about it again. 78-year-old woman said, I thought I'd take the secret to my grave. Nobody asked, so I figured nobody cared. So I think we can learn a lot from this study in many, many different ways, And as I said, it started with the 17,000 people. It went across this country. There are now over 2,000 studies around the world that have found exactly the same correlations. For people who have 4 or more yes answers to those 10 questions I gave you, 4 times more likely to have anxiety or depression, 6 times more likely to engage in illicit drug use, 6 times problematic alcohol use, 7 times to have experienced violent victimization in their adult relations, 10 times to have problematic drug use, 30 times more likely to attempt suicide. So how we cannot be bringing this to all of our mental health services, all of our behavioral health services, well, I think personally, I think it's an ethical issue. So becoming trauma informed is information about trauma. So what is becoming trauma responsive? And as I said, this is where we take what we know and figure out what we need to do with it. And this is where I said policies, practices, the environment, and so forth. Now, there are core values to trauma responsive environments. And this comes from the work of Roger Fallett and Maxine Harris, who really developed this term trauma-informed care many, many years ago when they were running a very large community-based mental health center in Washington, D.C. Safety, primary, so 5 core values. Safety. There has to be physical and emotional safety in the environment. You maximize trustworthiness, you maintain boundaries, you make tasks clear. Sometimes this can be represented as something as simple as, if it says group's going to start at 2, you start at 2. You don't start at 2:15 or 2:20. If you say you're going to call somebody back, you call them back. Choice, emphasizing individual choice and control. And we know that many treatment programs today, I can go into a treatment program, somebody will say, here, Stephanie, here's what you're going to do here. I could look at it and say, well, I don't know if this is going to help me. And the response can be, look, your best thinking got you here. Just do what I'm telling you to do. That's not about choice. And that's not about having a sense of collaboration. You know, basically in a collaborative, mutual therapeutic relationship, we're in this together. And if I'm in the clinical role, I'm here because of my experience of helping people on this path to recovery, not because I'm telling you what to do. And then empowerment, striving for empowerment and skill building, how to develop coping skills, how to learn to live in the world, particularly without coping through the use of alcohol and other drugs. So one of the things I'm going to suggest to you when you think about becoming trauma responsive is for you to do a walkthrough of the place where you work. Over this next week, when you go back, just kind of what you might do is imagine yourself as a client. Pick a client, certain age client, whatever you'd like, male or female, with a trauma history. And then I'd like you to start from outside the entry to your program and just think about what it's like to come there and to be there, okay? And then after you get inside, I want you to walk through and think about the signage, okay? And I'm gonna show you some things and then I'll tell you about experiences people have had with this. So we often don't think a lot about our signs. Here's an example. Denial ends here was a big banner in a substance use disorder treatment program. Denial ends here. And after working with this agency through the lens of trauma, the banner came down, and hope starts here is the banner that went up. And just think about, if you're a new person coming into treatment, what engages you? What gives you even a sense of safety, as simple as 3 words on a banner? Here's a sign that was in a women's treatment program. Attention, giving tox screens is not optional, effective immediately. If a client's on the tox list and leaves 2 consecutive times without giving, she may be discharged. Very clear, very clear. Here's the new sign. To all of our Lifeline clients, kindly check the tox list at the front desk for your name, both before and after group. If your name's on it, we're requesting you provide a tox screen before you leave the building. If you have any concerns, please do not hesitate to discuss them with your clinician or Terry, Lifeline's case manager, appreciatively. Same information. What do you feel like being compliant? What do you feel like doing? And what do you feel like resisting? All the same information, but how it's worded makes a huge difference. And I'm going to show you some photographs, some pictures of things, of what places did, okay? And we'll talk about why this is important. This is a women's program, residential program. You'll see the living space on the left, and on the right, you think, well, they spent a lot of money. Well, actually, they became very clever. They contacted a local interior decorator and said, we don't have any money, but we've got to spruce up. We want this place to look better. And she said, we know a lot of the people I work with throw out really pretty good used furniture. And so this was all donations, okay? So why would something like that, or like this, just to focus in on the window, make a difference? For many people who've experienced trauma, what happens in the mind can be a lot of chatter, a lot of chaos, often having grown up in chaotic environments. Now you look at these 2 pictures, and where are you going to feel calmer and more comfortable? As simple as how the draperies look, right? Simplicity, no chaos. Also in this program, they had a lot of dark furniture. The rooms were pretty simple. You'll see what they did. They painted it and they lightened everything up. This is a community-based program, moved into a new space. They were so excited to have so much space. And when you walked in the main door, you came to the room on the left. And you'll see the big sign that gives you the arrow where you're going to go to the receptionist. Stark, doesn't look engaging, have to go around the corner. So they took that space and totally, now, one thing is you move into new space and it takes a while, but this is a couple of years into being in this space. That's how it was. So they took that wonderful space, and many people came with their children, and they created these areas for children, and they created a reception space in the beginning when you walk in versus having to go to the end of this large room and turn left. This is a hospital area, sort of a small waiting room, had a love seat. Problem is when you put love seats into waiting areas, most people don't want to sit on a love seat with a stranger. And so also it's rather bleak. This is that same area, putting more of a mural on the wall and separate chairs with space between the two seating areas. This was another hospital area. This is in a different place, but they were, in this area, they can't put anything on the wall that has glass. And so they found things that could be like stuck on the walls. This is another place where they did things on the walls. They couldn't hang things either. And so they did a lot of stencils, positive statements on walls. Here you see the bottom picture here are those 5 core values are stenciled on this wall. Okay. Safety, trustworthiness, choice, collaboration, and empowerment. Here's a community-based program focusing particularly mental health. And they had realized that what would be important would be to have a space that the men could go into that would be a quiet space, and that they could get out of the hubbub things. And this is what it looked like as they started the process of becoming trauma-informed traumers. This is what it looked like. So when you look at it, it's not particularly warm and engaging, but this is what it looked like afterwards. The space has now been transformed into some place that feels peaceful, feels like a space you might want to move into. Now this next one, this is the women's quiet room before and after. I love this picture. We always, of course, want to put the ironing board in the women's quiet room. You can't see in another corner, there was a bucket with a mop in it that the cleaning people kept in the women's place to be quiet and their safe space. And also I want you to look at remember the size difference. We had this size, this is the men's space, the women's space. But this is how this space got transformed. So everything can be improved. There's always room for improvement. So I want to share with you this idea when I said walk through, story of a man that was in a training I was doing, and he called me several months after the training and said, I did that walkthrough. And he said it sounded like kind of a dumb exercise, but I decided to do it. And he said, I've been the director of this program for about 25 years, and I stepped out. It was about 6 o'clock at night. You have hours till about 8. I told the receptionist I was coming in. I was going to role play a new client. He said, I went out in the parking lot, and he said, I had decided to role play 35-year-old woman who'd been raped at age 18. He said that wouldn't be uncommon for the people we serve. So he said, I realized I wouldn't know where to park my car. 6 o'clock at night, it was dark. We have 2 lights in the parking lot. The spaces close to those lights were taken. He said it would be hard for me to park in the dark and walk to the front door if I was a woman, and particularly if I'd been abused. He said, I walked in the waiting room. The chairs were disheveled. We'd seen clients all day. There were cookie crumbs on the floor because often people bring their kids. Magazines are in disarray. And he said the receptionist keeps her sliding glass door closed. So he said, I realized I would have to have a lot of initiative to walk up, tap on the window, which I did do, he said. And I said to her, oh, I have an appointment with Mr. X, Y, and Z. And she said, oh, go through this door, go to the third hall on the left, turn left, then go to the second hall on the right, turn right, and it's the fourth door on the left. And he said, if I had any anxiety at all, I wouldn't even get to that office door. He said, I forget it takes a month for, we're big. He said, it takes a month for new staff to find their way around. So what did he do? He put lights in the parking lot. The receptionist now tidies the reception area 3 times a day. They changed the color of the walls, which he said looked depressing. She keeps her sliding glass open unless she's on a confidential call. And all the clinical staff come to the waiting room to pick up their clients. That's becoming trauma responsive. Okay. To make these changes, organizations need a team to guide it. There needs to be a leader. There needs to be some people that really champion trauma, that are always reminding people of using a trauma lens. And it's really good if you can have some people on the committee who in fact are people being served by the agency. So for example, maybe you've been a member of an agency who starts an initiative and there's a committee that does it, but no one really ever knows what's going on. They're not even sure who's on the committee, right? It's really important that everybody in the organization understands who's on the guide team. So this is an agency that the guide team created a picture themselves. Those are the 5 core values. It's the Trauma and Gender Initiative. Posters were put up everywhere so that the over 1,000 employees in multiple sites knew what was going on and who they could contact if they wanted information about how this initiative was moving forward. And the guide team uses a plan. You know, becoming trauma responsive is a changing culture, takes time. It really does. So we use the 5 core values as one of the areas to do the self-assessment, but also the service policies, the foundation program design, how you do assessment, what kind of services you provide, what kind of administrative support you have, what kind of training and education, human resource practices. And so, for example, here would be the implementation plan. So for clients who are female identifying, are there any safety issues? Because you're going to be doing an assessment in all those domains, including the 5 core values. So any safety issues for women, how would you resolve it? Who's going to be responsible? Who will also be on the team? How long do you think it's going to take? And then at the end of that time period, you look back, how did we do? Did we meet our goal? Do we need to work on it longer? What did we learn? Does something else have to be changed? So there's a structured process to organizational change. We have this also for those who identify as male, but notice we also have it for staff. The same issues, those same 5 core values we are assessing in terms of staff. And it's different for the female staff versus the male staff. You know, in one state, I was working with the Department of Health and Human Services, and we had these huge meetings with lots of people representing the multiple agencies of the state. And they were doing some tasks in small groups, and I was walking around the room, and one group were working on this, and the woman said her thing was lights in the parking lot. And the men said, no, there's enough light in the parking lot. And the woman said, well, maybe there's enough light for a man, but there's not enough light for a woman. And so when we think about safety, sometimes women and men see safety differently. The other thing about staff is it's really important that you have a sense that and an understanding that you can be impacted by trauma. It can happen in your life in terms of your childhood and your adolescent, your adult life, of course, but also you can be impacted indirectly by trauma by the work you're doing. Okay? And this process has several names. Sometimes it's called vicarious trauma, compassion fatigue, secondary post-traumatic stress, or burnout. So there are a variety of different names for this, but it's really important to acknowledge that that this can happen. And you know, when we're working in behavioral health settings, we're seeing and hearing about the impact on others' lives, and that can take a toll on us. You know, it's a a heavy weight, if you will, to carry that. And people say, well, you should leave that at work. Well, sometimes that's not so easy to leave at work. And I'm also noticing with people that because of COVID and so many people are working remotely and doing a lot of virtual counseling sessions, they're doing this in their home. So there's no place to leave it at work. So it becomes even more challenging during this time period. Compassion fatigue is when you just don't think you can hear one more story. You just, the cup's empty, if you will. And what happens, people often become detached from work and they start making, there's errors in their judgment. We also can have, the symptoms of PTSD can be reflected in the staff in terms of avoidance and hypervigilance and having dreams and nightmares. And so thinking about yourself and how that is for you. And then there's burnout. And a lot of staff get burnout. Many of our organizations have been traumatized. And for a whole, lack of funding, people leave, all kinds of things. And so having staff also feel like, again, there's just nothing left to give. The other thing about burnout happens, and I have seen this, I do a lot of work in the criminal justice system, and particularly in that system, so often the policies and the practices that are in place are in opposition to the person's own values. And so if you're in a work environment where you're constantly breaking your value system, that's going to increase burnout. So when we think about trauma, we have to think not just about people seeking services, obviously, but also about impact on staff, and that these 5 core values have to be in place for staff. The safety, the trustworthiness, choice, collaboration, empowerment, all those things have to be in place for staff. And working with staff, do a lot of work around self-care and what that means. I always laugh because caregivers are usually the ones that have no idea what to do about self-care. And they often, what is self-care? They'll ask me. And I explain that self-care is really, it's things like eating healthy food, giving yourself a break, watching the funny movie instead of the intense drama, taking some time and space for yourself. And so here's an exercise that I really recommend to people. And it's something you can actually, we can do this right here, if you will. As I suggest taking a mini vacation. Everyone says they're too busy, right? I know that. We're all too busy. But if you could take 30 seconds, maybe a minute twice a day and do this, you'll be amazed at the change that can happen for you. And you do these 3 things twice a day. One is deep breathing. Okay. You breathe in through your nose. So do this with me. Breathe in through your, like you're smelling a rose, and out through your mouth. Okay. Like you're blowing a bubble. So breathing in through your nose, out through your mouth. Do that 3 or 4 times, twice a day. And then I want you to look around wherever you are and find something beautiful to look at. And as I said, I work a lot in the criminal justice system, and sometimes staff, they say, there's nothing of beauty here. I said, you have to look really carefully in your environment. Sometimes it's a sprig of grass coming up out of a broken piece of concrete, something alive. Often people comment on the orchids I have. Always keep something there. So looking at something beautiful. This may be harder to do because we're on virtual, but it's smiling at another person. It's just smiling at another person. So three ways to take, 3 steps to do twice a day as a form of self-care. And talking about trauma, we have to talk about the differences, the gender differences, and this is going to be the topic of our next webinar. But I wanted just to point out to you, in talking about and working with trauma, considering gender, that both boys and girls are at risk, particularly from family members, people they know in childhood. The differences occur over the lifespan. So young men are at risk from people who dislike or hate them. Very often, gay young man of color, gang member, his peers, police, someone who's transitioning, people who dislike them. Young women are more at risk from the person that they're in a relationship with, the person to whom they're saying, I love you. If we look at adult life, if a man is serving in the military, his greatest risk is from the enemy. If he's living in our communities in the free world, his greatest risk comes from being a victim of crime committed by a stranger. For the woman who serves in the military, her greatest risk is from the people she serves with. And if she's living in the free world in our communities, her greatest risk comes from the person to whom, again, she's saying, I love you. And we know that the LGBTQ and gender nonconforming folks are the ones at highest risk. So we have these differences we need to take into consideration. So remember, these are our 3 key elements for staff and clients, right? And so for those of you in particular who are working, I want to provide you with some resources. First resource, it's called A Brief Conversation. You'll find this on my website. And what I've learned, it's really that we can make a difference in 10 or 15 minutes. I was originally trained around trauma many, many years ago, that if I was working with a trauma survivor, I was going to work with them for multiple times a week for many years. And who do you think got that service? But now I know we can do something. And the brief conversation goes something like this. Someone coming into your program, this conversation can be adapted to a variety of situations. You can say something like, as we're talking today, I wanted to let you know that a lot of people who come here to get help have had some really difficult experiences in their lives. And I don't know if this is true for you or not, and you may want to talk to me about it or not, but I want you to know that we've learned a lot about this, and we have people here who know how to help. Also, when people first come here, when we're in a new place, it can be kind of anxiety producing. We may not feel comfortable. And it's really good to have some things we can do to comfort ourselves, whether it's here, coming to our program for the first time, or just life in general. So if you'd like, I could share these with you. We could practice them together. Or when you leave, you can take this sheet of paper with you. And we teach them and show them the breathing and exhaling exercise that we just did, which is the breathing in through the nose, smell of rose, blowing out the candle, right? Or blowing a bubble. And we teach the 5 senses exercise, which is, just look around you and name 5 things you can see. Just in this environment, 4 things, name 4 things to yourself you can touch, 3 things you can hear, 2 things you can smell, 1 thing you can taste. This very simple 5 senses exercise is not only self-soothing, but it puts someone back into the here and now, which is one of the most frightening things for people, I think, is that when there's been a trigger or a reactivator, it pushes the person back in time, and now they're experiencing feelings, sensations that belong to an earlier time and period and to a younger time and period. So having the capacity to get back into the here and now is a really important tool. And we use this thing that the five senses activity is like a card. And so you can download the brief conversation off the website and a page that has this, and then you can duplicate this card and pass it out to people. Another resource is the tier system. And this is a system of how you can organize and really manage a treatment service. Could be a custodial setting, could be a residential setting in particular, but how to use a trauma lens in terms of how you set up your organization. So I highly recommend this as a resource. We also have materials for our clients, women, that is helping women recover substance abuse and trauma, the 12 steps, healing traumas, a brief trauma intervention, materials for men, helping men recover, again, substance abuse with a trauma piece in it, exploring trauma, brief intervention, materials for youth. We have things for girls, things for boys and young men, and resources for staff training. Women in Addiction is a program development guide. And then moving from trauma informed to trauma responsive is how do you do organizational change with many of the things we talked about earlier. You know, I used a spiral before, and I use it a lot. I use spirals a lot, actually. I like them for a variety of reasons. I think it's a graphic, they're a good way for us to think about addiction, but also a good way for us to think about trauma and also about recovery and healing. And the other thing I like about them, I'll point out to you here, but let's start with the downward spiral. So think about this in terms of addiction. You're working with someone who has an addictive disorder. And my sense about this is they're caught in a downward spiral. And that line through the downward spiral is the object of addiction. It can be a substance, could be alcohol, drugs, it could be a process, sex, food, shopping, whatever. But as they're in this relationship with the object of addiction, and their life becomes narrower and narrower, becomes constricted. It limits the places they go, the people they see. There's all this constriction and limitation. That same process happens with trauma. So the trauma survivor, then the line through the middle can represent a traumatic experience or experiences. And very often the person organizes their life around that. And again, constriction takes place. Certain people they can't see, there's certain places they can't go. Sometimes the constriction is layers of clothing. Sometimes it's extra weight. But there is this sense of constriction and limitation. Part of our work then is to help the person move off the downward spiral onto the upward spiral of recovering and healing. And this upward spiral, again, it's recovery from substances. Now, no one's recovery is this perfectly symmetrical spiral. It looks good on PowerPoint, but we know it's a little more uneven than that, but we want it to be in the upward direction. The other thing about the spiral that I like, I'm not sure if you can see my cursor or not, but the upward spiral, it's sometimes in issues on the background, sometimes it's in the foreground, right? Sometimes it's in the background, sometimes it's in the foreground. And this is true for recovery over time. As someone's recovery becomes established, if you will, they'll find that they sometimes can pay less attention to it. Whereas in the beginning of recovery, they may go to 90 meetings in 90 days. They may be much more in touch with their support system than perhaps a number of years later, where they still have the support, but there are times that the addictive disorder is more in the background. And this is also true with the healing of trauma. In the initial work, trauma is very much in the foreground. But over time, right? The difficulty with this is that so often people think, now I'm in recovery, I'm done with this. Oh, now I've done trauma work, I'm done with this. And what I want you to see from the upward spiral is this spiral goes on and on throughout life. Any major life event stays with us all of our lives. It is the nature of life. And so it's been one of the hardest things, I think, for some of the people I've worked with who are trauma survivors, because they want this to be gone. And I have to say, no, it's not going to be gone. It's the nature of life that whatever are our major life events, they're part of who we are and how we are. And our challenge is to be able to manage it and be able to grow from it and be able to have more space, more things in our life, more people in our life, that this is not our sole focus, but the line in that upward spiral, that line in the upward spiral is with us throughout our lives. And I often use this analogy with people that we can say, okay, let's imagine that 30 years ago, I broke my arm and my arm is healed. And for whatever reason, I have to go and get my arm x-rayed. The person reading that x-ray will be able to say to me, you know, Stephanie, I can see that you had a break in your arm many years ago. There'll be a trace. It's not going to be gone. There'll be a trace. But that person will also let me know that I am now strongest at that broken place. And that's what we want for the people we serve. How do we help them become strongest in those broken places? How do we help them become strong in those broken places? So I thank you for spending time with us today. And we're going to take some question and answers with the time we have remaining.
All right, Stephanie, I'm going to take over the remote control.
It's yours.
So yes, the Q&A. One of the questions is, can links to the recording be sent to my email? Yes, we will. At the end of this presentation, everybody will get an email. Everybody who attended will get an email thanking them for your time and with a link to the presentation. And I will also it will also give you a link to the evaluation where you will be able to quickly go through and evaluate today's presentation and then respond back with me with some basic information that is on the evaluation. I see that lots of people have put their information on the, lots of people put their information into the chat. One person has asked, do you recommend or advise that males also be included in a female-only recovery program?
Well, over the years, I've had various feelings of years ago. Those of us that developed women's services said that only women should be working in women's treatment. And then we met women that shouldn't work with people. And so I believe that you have to really be thoughtful about who you hire, period. So when working with women, we have some questions you can ask people, and you're listening to their answers regardless of how they identify in the world. And if you're going to have men working in women's treatment, the most impactful place to use them is in a non-traditional role, because it really gets women's attention. If you have a man running a domestic violence group, or if you have a man running a parenting class, the women really pay attention. If you have a man running the women's treatment program, the women are used to men running things. So that doesn't really bode well. So if you're going to have men in an all women's treatment program, you want to think carefully about who you hire and what role they're going to play. You know, part of it is men and women live in different worlds. We live in the whole world together, but we have very different lived experiences. And any man working in a women's facility needs to really understand women's culture and women's world.
Very good. Let's see. I'm gonna go over here to this area. Let's see. If anybody has questions for Dr. Covington, if you'd put it in the Q&A, there's lots of information in the chat about people who are, let's see here. Okay. We do have lots of questions about our first session that we did. The first session was treating addiction in the 21st century. We did that back in, gosh, December. And that was, CEUs were not offered for that one, but I will send a link. So anybody who is interested in seeing that can watch it. It was a great presentation by our friend, Dr. Covington. CEUs will be, one CEU will be offered for this presentation, as well as the one coming up in June. Does anybody have any other questions? Okay. Hold on. Is there a workshop for becoming trauma responsive?
You mean like having a training? Here's what I'll suggest to you. If you look on my website, we have a calendar, a schedule of different trainings. Most of the time when there is a training on becoming trauma responsive or moving from trauma informed to trauma responsive, usually an agency has us work with them as a team over a period of time. Another thing that people do is they buy that material, moving from trauma informed to trauma responsive, and then sometimes they have a trainer work with them to help them navigate the material. Even though the material is set up for you to do it on your own, sometimes people want some help with it. So there are a variety of ways. We don't generally just run a workshop on becoming trauma responsive that's open to everybody, because there are a lot of individual issues in agencies, and we have found that it's better if we work with one agency, but a group of people at the same time in the same location, or for some of the larger agencies, you know, with multiple locations. But if you follow the schedule, the calendar that's on my website, you'll see what we're offering over time, and it's changing all the time. I'm sure Laura in my office probably updates it every week or two.
She does. Laura's great.
Yeah.
Laura's, the other Laura is what I call her. That's Stephanie's fantastic.
She makes this all happen.
She really does. She really does. We have another question. Do you recommend any group for staff before they join a program, training for staff you recommend?
You know, one of the things recommended over the years to people is that if you're going to, a couple of thoughts about that question. If you're going to use an intervention with your clients, certainly the things that I write, we offer training. However, one of the most powerful ways to train staff is to have them go through the program material themselves as participants before they facilitate it. So for example, we have Exploring Trauma, which is a 6-session brief intervention for men. One of the states, a state that really surprised me, decided we trained their staff in that intervention, and that group is open for staff to volunteer and be a participant in a 6-session. They're going to run 6 sessions for men, 6 sessions for women, for staff before they ever take it into the prison system. So this is a Department of Corrections in a state that I would not consider the most progressive I've ever worked with, but they decided they wanted this available to their staff first. We certainly have treatment programs that have their staff participate as a group doing helping women recover, helping men recover before they use the intervention with their clients. So that's one way for staff to be able to see where some of their own issues come up. And let me tell you, it's, as a staff person, it's much more comforting to realize, gee, I've got an issue here when I'm in a staff training than when I'm facilitating a group with clients. That's usually a more difficult time to realize, oh, wait a minute, I have some work I've got to do about this myself. So hopefully that answers your question.
Very good. How do I get my facility to be on board for being trauma responsive?
It's the hardest piece. Everybody wants to be trauma informed, and they think they're trauma informed because their clinical psychologist went to a weekend training. The trauma responsive piece is the hardest because it's really about organizational change, and any of you in organizations know organizations don't change easily. You know, you talk to your colleagues about it, so you have a sense of support, and you take it to the leadership at the top and say, you know, we've done this, we've learned about trauma, but we realize some of our policies and practices are really antithetical to how it should be since we're working with trauma survivors, and see if you can get some buy-in at the top.
Very good. Thank you. Many times children are removed from their parents specifically related to drug use or addiction. What is your experience of adults recovering or working through treatment when separated from their children?
Lots of, you know, it really depends on the family, it depends on the person. For many women, getting clean and sober, they do this because of their children. But they have to know their children are coming back. And in some cases where there's been so much abuse and neglect, we can understand why the children were separated. But the foster care system in this country is nothing you would want a child to be in. So reuniting families and giving families adequate support, one of the most difficult things very often is when parents have gone into treatment and they've started their recovery, and the reunification process may start so soon that this becomes a huge stressor. There need to be a lot of supports in place. It's a challenge. I think it's very much a challenge.
Okay, thank you. Do you see an increase, decrease, or about the same in social media trauma over the past few years? What are treatment approaches for this?
Well, I think that social media has increased over the past few years, and I think the misuse of it has increased. And I'm particularly concerned about young people and what happened. You know, several of my friends have daughters in particular in high school age, and have told me with high school being closed because of COVID and doing homeschooling, their daughters have flourished because they're not getting the comments, the competition, all kinds of things that were part of their normal everyday life haven't happened when everything went virtual. So I think that tells us a lot, and I think that's incredibly unfortunate, and it's not good for young people. It's not good for older people. It's really not good for young people. So yeah, I'm concerned.
Very good. Thank you. Does anybody else have any questions? Is there something that we haven't answered that perhaps I missed? Anyone? Okay. Well, our next session with Dr. Covington will be June 10th, and it will be on gender being the missing link of treatment. And Dr. Covington, like I said earlier, literally wrote the book on gender responsive treatment and trauma. So we are super excited about that. And again, there will be CEUs offered for that one. We will offer one CEU. I will be emailing the link to the evaluation. Actually, let me do this real quick. I'm going to share my screen that shows you exactly where you can. I'm going to stop sharing this and I'm going to, let's see. Here is where you can get the evaluation. It's at www.tinyurl.com/PCRR, that's Plum Creek Recovery Ranch webinar. So that is where the evaluation is. And I just got a note here. We do have a fabulous website. Please do keep an eye out on our website for any upcoming events. We will start accepting patients later this year, first part of the January, February, March, second quarter, first part of the second quarter. We are anticipating being able to take patients. So you'll be able to get information on that on our website. Our website has all sorts of great information. Let's see, there's something that just came through the chat. Let me make sure I'm getting all of the information. What I don't want to do. Do you advise ACE as part of intake?
You know, have to realize people are using ACE all over the place. It was never meant as a diagnostic tool. It was meant as a way to gather information and then correlate it for large numbers of people. Now, I do think that there's a place for it in order for people to think about their life history. And so you'll see we use the ACE questions in some of the material, some of the program materials. So I don't know that I would do it right at intake, but at some point, if you're doing trauma work, I would use it as a way for people to think about their own risk of what it can mean to have these childhood experiences.
Okay. All right. Thank you all so much for joining us. It doesn't look like we have any more questions. We had a great turnout and we really appreciate everyone's time, and be on the lookout for our next event happening June 10th. Everybody who attended today will get an invitation to join that as well. So thank you all again. We look forward to seeing you soon. You guys stay safe. Bye-bye.